Hi there, it's Dr. Atkinson, and today we're covering a condition that affects millions of people every year, rhinosinusitis, both acute and chronic forms, along with the nursing care and clinical judgment involved in recognizing complications and providing safe treatment. Let's dive in. What is rhinosinusitis? Rhinosinusitis is inflammation of the paranasal sinuses and the nasal cavity. You might hear people refer to it as sinusitis, but the correct term now includes the rhino prefix, because sinus inflammation almost always occurs alongside nasal mucosa inflammation. It's incredibly common. About 35 million people are affected annually in the US, leading to 16 million office visits a year. We classify rhinosinusitis by duration: acute, less than 4 weeks; subacute, 4 to 12 weeks; chronic, more than 12 weeks. Acute rhinosinusitis, ABRS versus AVRS. Acute rhinosinusitis can be bacterial or viral, AVRS. It often follows an upper respiratory infection, and when the sinus openings become blocked by inflammation, fluid builds up. That creates a perfect environment for bacteria to thrive. Obstructions may be caused by deviated septum, nasal polyps, hypertrophied turbinates, tumors, even swimming, diving, or dental infections. Common bacterial pathogens include Streptococcus pneumoniae, Haemophilus influenzae, Staphylococcus aureus, Moraxella catarrhalis. Biofilms. Dense communities of bacteria play a major role in resistance. These are tough to eliminate because antibiotics can't fully penetrate them. Other occasional culprits include chlamydia pneumonia, fungal organisms like Aspergillus, and healthcare-associated bacteria like Pseudomonas and E. coli. Symptoms: ABRS versus AVRS. ABRS presents with purulent drainage, front or back, nasal obstruction, facial pain, pressure, fullness, and the cheeks, eyes, or forehead. High fever, over 39 degrees Fahrenheit 102 Fahrenheit. Symptoms lasting 10 days or more or worsening after initial improvement. AVRS is similar but milder. Symptoms last less than 10 days, no high fever, less facial pain or pressure, doesn't worsen over time. Assessment and diagnosis. Assessment focuses on nasal discharge, color, quantity, pain and facial tenderness, sinus percussion and palpation, visual inspection of nasal mucosa for erythema, swelling, or polyps. Transillumination may show blocked sinuses. Imaging isn't usually needed unless complications are suspected. If needed, CT is preferred over X-ray. Endoscopic cultures or sinus aspirates help confirm the organism if treatment fails. Complications. If untreated, acute rhinosinusitis can lead to osteomyelitis, mucocele, orbital cellulitis, meningitis or brain abscess, cavernous sinus thrombosis. Frontal infections can lead to soft swelling over the bone, doughy edema. Ethmoid infections can progress rapidly, threatening the optic nerve. These are medical emergencies. Medical management. Acute antibiotics are prescribed only for confirmed or strongly suspected bacterial infections, typically when fever is 39 degrees Celsius or higher, symptoms persist 10 plus days, symptoms worsen after initial improvement. First-line antibiotic, amoxicillin, with or without clavulanic acid. Alternatives, doxycycline, levofloxacin, or moxifloxacin for penicillin allergies. Avoid older generation cephalosporins or macrolides. Resistance is high. Supportive treatments, saline nasal lavage, helps clear mucus and reduce inflammation. No antihistamines or decongestants in ABRS. Intranasal corticosteroids only if allergic rhinitis is also present. Medical management. AVRS, viral sinus infections are treated symptomatically. Saline sprays, oral decongestants like guaifenesin, pseudoephedrine, topical decongestants for no more than 3 to 4 days, antihistamines if allergy is suspected. Chronic and recurrent rhinosinusitis. Chronic rhinosinusitis, CRS, lasts more than 12 weeks. Recurrent acute, 4 or more ABRS episodes per year with no symptoms in between. Typical causes: structural issues, septal deviation, nasal polyps, environmental exposures, chemicals, smoke, comorbidities, GERD, immunodeficiency, cystic fibrosis. Common symptoms: chronic nasal congestion, mouth breathing, chronic cough, morning fatigue, hyposmia, decreased sense of smell, snoring, sore throat, and even ear fullness. Assessment and imaging in CRS. In CRS, we go deeper. Physical exam of nose, sinuses, and oral cavity, inspection for anatomical deformities, imaging studies, CT, endoscopy, swabbing for bacterial or fungal cultures, history of asthma, smoking, or ENS use. CRS complications. Though rare, CRS can cause intracranial infections, meningitis, brain abscess, orbital complications, cellulitis, vision loss, frontal bone osteomyelitis, cavernous sinus thrombosis. Neurologic signs include personality changes, seizures, focal deficits, and changes in consciousness, all red flags for escalation. Medical management, chronic and recurrent treatment includes long-term antibiotics, 2 to 4 weeks or longer, intranasal corticosteroids like fluticasone or beclomethasone, decongestants, oxymetazoline, pseudoephedrine, NSAIDs or acetaminophen for pain. Mast cell stabilizers if allergy is suspected, leukotriene inhibitors for patients with asthma or nasal polyps. Lifestyle, avoid smoke, fumes, caffeine, alcohol, sleep with the head elevated, stay hydrated. Surgical management. If symptoms don't resolve with medication, patients may undergo functional endoscopic sinus surgery, FES, a minimally invasive procedure that improves sinus drainage. Relief rates are excellent with 85 to 91% improvement. FES may include removal of polyps, correction of a deviated septum, drainage and aeration of the sinuses, tumor excision, computer-assisted navigation for precision. Fungal infections require urgent debridement and antifungals. Nursing management and education. This is where your patient teaching skills shine. Key points: gentle nose blowing only. Forceful blowing worsens symptoms. Use warm compresses, increase fluid intake, and elevate the head. Teach proper use of nasal sprays. Incorrect technique can cause irritation, epistaxis, and bad taste. Rebound congestion is common with overuse of decongestants. Encourage smoking cessation and avoiding swimming or air travel during infection. Teach early signs of complications: fever, severe headache, neck stiffness. Use large print or translated materials as needed. Reinforce medication adherence. Explain why consistency matters. And always assess for immunocompromised status. Patients on chemo, post-transplant, or those with immune deficiency may not show typical signs and are at high risk for life-threatening fungal infections. Final takeaways. Let's wrap it up. Rhinosinusitis is common, but its complications can be serious. Know the difference between ABRS and AVRS. CRS and recurrent acute sinusitis require long-term strategies and possibly surgery. Fungal infections in immunocompromised patients are an emergency. And as always, education is prevention. Help your patients understand how to care for themselves safely and when to seek help. Thanks for listening. I'll see you in the next session.